Hello, hello, hello. It is not a glitch, it really is me. I really am back. Hi guys, welcome back to my channel. This is Foxy Chikisi, and I've rebranded my channel and it's now called On the Way to PA. So it's still me, it's the same person, I just switched some things around. But welcome back guys, thank you so much for coming back to my channel. I have new content obviously because I'm here. And so much has happened since my last video. I had said I was going to record a video for each semester. Clearly that didn't happen. But I'm here now, and all the things that have happened are all good things. So I'm going to update you guys. I'm going to just bring us all up to speed on everything that's been going on. It's been a wonderful journey so far, and I'm really excited to share all the information. So I'm going to give you all the tea. That's my dog. I don't know if you can hear her scratching down there. Nice addition to the audio of my video, but anyway, let's move on. If this is your first time on my channel, I'm gonna just introduce myself real quick. I am a PA student. I am now a second year PA student. I am in the state of Indiana. Excuse me. I am in the state of Indiana, and I am now at the stage where I'm getting ready to head into clinic rotations because my whitefoot ceremony was actually yesterday. Excuse me while I pick my pen up. Got it, we're back. Yeah, my whitefoot ceremony was yesterday, so like I'm literally at the point where you transition between didactic classroom year and clinic. So now I have the time to come record this video. But yeah, that's who I am, that's what I do. Obviously you saw that because you clicked on the link to get to this video, but just a little introduction. If you have not watched any of my other videos, the very first one, I kind of spoke about my whole experience with applying to PA school because my GPA was low compared to a lot of other applicants. And I discussed the details of my application and my hours and all the things that I had and the whole package I put together and how I was able to get into PA school. So if you want to watch that, just go on my channel and you'll find that video and you'll get much more history on the application process because this is more about the educational process while in the program. Okay, so the last video I recorded was talking about the fall semester because we, I believe, had just finished that and we were starting the spring. So we finished the spring semester. We finished the summer semester as well, so we're going to talk about that. And we had the ceremony yesterday where we got coded. Actually starting clinic this coming week, so that will be fun. And a lot of questions that I got about my previous videos about working. I still work. I am still employed. I know, it's a shocker. Like, I didn't think I'd still be employed at this point in time, but I am. So here we are. Yep, I'm still working. Barely, I'm still working. Okay, so the spring semester, we took 18 credit hours. It was only 2 courses, like I had mentioned in the last video. It was clinical medicine and patient evaluation. But clinical medicine by itself was 15 credit hours, and it had 9 modules. And then patient evaluation was the other 3, so that made the 18 credit hour course load for the spring semester. This was 9 modules of clin med, and a lot of the ones that are heavy in the pants were the ones that we took in the spring semester. So it was quite a bit of a workload. So the modules for clinical medicine that we took were cardiology, EKG, endocrine, ENT, GI, nephro and urology were kind of lumped together, so it's 2, but I counted as 1. Neurology, pulmonology, respiratory, and rheumatology. So 9, 10 modules, I guess you could say. And like I said, a lot of these are the ones that are the heavy hitters in the pants. We started off, I believe, with EKG, and EKG can be covered within cardiology because obviously it's the electrical patterns of the heart, but I think we started it there so that we could have a foundation to go into cardiology with. It was very short, so a lot of these modules overlap, obviously, so that we can get them all done in one semester. I had 0 background in EKG. I struggled because my background is in radiology, and I had never had to read an EKG. I had never had to look at one and know what was going on, you know? So very niche experience that I had that did not overlap with EKG at all. Some of my classmates had experience with recognizing patterns. I had 0 clue. So the first test, I struggled, and then I kind of buckled down. And as with anything, the amount of effort you put into it will pay off, and it paid off big time because I struggled, but then I eventually got it. And the key is exposure. Just keep looking at strips until you recognize what you're looking at. Keep looking, keep looking. You'll see, once you look at that many normal strips, you'll know what an abnormal one looks like. And you may not know what exactly is wrong, but you know something is off. And then as time goes on, you'll be able to recognize what is actually wrong with it. Okay. Then we did cardiology. Cardiology is huge on the pants. I mean, it's huge in medicine in general because what is the number one killer of people in the U.S.? Heart disease. So as a medical provider, you should be pretty up to date in heart disease. Even if that's not your specialty, a lot of your patients will have some type of heart condition, be it a valve condition, be it a cardiomyopathy of some kind, be it something infectious, even if it's something traumatic. The heart is kind of a big deal in the body, so cardiology was a really big one, and it was a lot of information. Hypertension and how to manage it, huge deal. Learning all of that at once, it was an overload. And then you just sit down and you're like, okay, I can do this, I can learn this, and now I actually really enjoy cardiology, and it's one of my favorite subjects. But it's definitely a lot to learn for a good reason. And then we did endocrine. Endocrine, to me, I really enjoy endocrinology, the pathways, the hormones, excess of hormones, not enough hormone, at what stage, how do you treat it. I feel like it's really basic because it's like they don't have enough of this, they have too much of this. Do we give them more? Do we give them something to mitigate their symptoms? How do we treat it? Is it permanent? You know, I feel like it's very too much, too little of the hormone, and then you fix that and you're fine. And then you also figure out what the crises are, like a thyroid storm versus a hypothyroid situation where the person is like super bradycardic. So I felt like endocrinology was really simple to understand. And then ENT is kind of a overlap of your infectious disease, sinusitis, you know, up here, all of this stuff that can go on in the airways up here, your eustachian tubes, your ears, hearing loss, you know, vocal cord stuff. And it was really big on clinical, what's clement, but like knowing what antibiotic to give for what situation. Like the endocrine stuff, a lot of it is more, okay, we're gonna give a hormone substitute and something for symptomatic treatment. But with ENT, a lot of it is infectious because you're breathing in all this stuff, you know, you tend to get a lot of infectious processes, and you also have to know your pediatric stuff there because little kids have all these boogers that you have to fix. So that was, to me, that was kind of our first introduction to using antibiotic therapies appropriately and understanding the flowcharts and the algorithms for, oh, I'm going to use this versus no, wait and see, 10 days, double sickening, don't give them an antibiotic, the body will fight it, viral versus bacterial. So I enjoyed the ENT. I thought it was a pretty good module. GI, another super heavy detailed one. Very big on the pants, obviously. And the thing with GI is you have your digestive tract, obviously, and then you have the accessory organs. You've got your liver. You have to know like your hepatitis and your cholecystitis, which every single patient will come in with a cholecystitis and will get a gallbladder removal. And then you have your pancreas, you have your pancreatitis, you have your pancreatic cancer, and then as you go further down, you have the colon, and of course you have colon cancer, which is a huge deal. And then you have your autoimmune stuff that affects the gut. You have your celiac disease, you have your food allergies and sensitivities, you have your ulcerative colitis and your Crohn's. So you have to know all of that as it affects the GI system, what to do with it, how to treat it, how to recognize it, what to test for, what diagnostic studies to order, you know, what blood work to order. So GI was way more involved than I thought it would be, and a little bit of struggle. There was a lot of struggling this semester, but I enjoyed GI, and so I'm glad I did, because you can get your differential for cardiology and for GI can be a mile long. Honestly, it can be a mile long. So it's really good to have a good base understanding of what you're doing and what you're looking for. Nephro and urology. So nephrology is more your kidney stuff, obviously, and then urology is more your structural stuff, the pathway. So nephro is more medical, and urology is more surgical. So in urology, we'll learn a lot about this is how this problem presents, and this is the surgery we do to fix it. And this is when we can't do the surgery. This is when we wait. These are congenital conditions that we fix, you know, stuff like that. And then with nephro, it was more, oh, this is what we test the urine for to see what's going on with kidneys. These are the imaging studies we do to see how the kidneys are doing. This is what happens when someone is born without a kidney. You know, this is nephrotic syndrome versus nephritic syndrome. What kind of cast did you see? What kind of urinalysis would you do? And what would you see in the urine that would lead you in one direction versus another? And then understanding when someone is heading towards CKD or chronic kidney disease, and if they're heading towards end-stage renal disease, and how to counsel them on, hey, you might have to be on dialysis, you know, and we might have to put you on the kidney transplant list. Understanding what kind of medications someone that has kidney disease should avoid, you know, and kind of understanding also how systemic diseases in other parts of the body affect the kidneys. Hypertension, of course, is your number one. Hypertension will jack those kidneys up every time. So just understanding those things and understanding that patients with kidney conditions, you really need to consider that, because a lot of drugs are metabolized renally, obviously. I mean, everything in the body, the whole blood is filtered through the kidney. So when you know that someone has a kidney condition, you really have to manage them differently to make sure that you don't exacerbate what is already bad in there. So I enjoyed nephro and uro, and like I said, urology is more of a surgical subspecialty. There's a problem, we fix it, boom. Nephro is more, we're managing, we're adjusting drugs, we're making sure we don't do anything to make things worse. So I enjoyed the combo of those. And then we had neurology. So neurology is more the wiring of the brain. So with neurology, we did stuff like, how to manage headaches and recognize what different types of headaches there are, your red flags, your danger signs, your subarachnoid hemorrhages, your subdural, your multiple sclerosis. That's another, demyelination situation with the nerves and the wiring. Recognizing concussions, testing for them, screening tests, when a person can go back to playing sports after getting a concussion. Your Parkinson's, your traumatic brain injuries, all of these things that have to do with the wiring of the brain, the structural integrity of the brain, and pathologies associated with that. So I enjoyed neuro as well. This is a pretty good module. Pulmonology. Honey, let me tell you, this module tested my life, snatched my edges, came for me. This was so hard, and it was so hard because it was so detailed. I said cardiology and GI were detailed. Respiratory, woo! Obviously, you can't breathe, you die. So we have to know everything about the lungs. There is so much stuff that goes on with the lungs that I had no idea about. And you have all these scores and all these things you have to think about. Obviously, you have your basic stuff. You have your COPD, you have your asthma, you know what I'm saying? You have your pneumonia, and then you have these scores you got to calculate, and then you have to know what antibiotics to use. You got to know, what's going on with the lungs. Are they, do they have an autoimmune problem? Are they immunocompromised? Pulmonology is deep. It's deep. It's really deep, and I think I did the most work in this module. You have to know, like, your inpatients, your ventilator. When do you ventilate? Will they get ventilator-associated pneumonia, community-acquired pneumonia, hospitalizations? When they get hospitalized, did they get the pneumonia from your hospital or did they get it from the community? You know what I'm saying? What are the organisms, the causative organisms? Do they live in a dorm? Do they live in a nursing home? All this stuff. Cystic fibrosis, bronchiectasis, bronchiolitis. I'm going all day about it. But it's very, very dense for a reason. Everybody's going to show up with some type of cough. Everybody's going to show up with some type of flu situation, and then their O2 stats are not looking good, and you got to figure out what to do. No matter where you are, there's going to be some stuff that has to do with the lungs. A lot of medications affect the lungs. Your alpha and beta drugs, you have to be careful which ones you use because some of them will cause bronchoconstriction. So knowing all of these things and tying it together was a workout for the mind. But I conquered it, I feel like. But yeah, definitely very deep with a lot of content. A lot of content. Pulmonary embolisms, VTEs, well scores. Oh my gosh, you have flashbacks. Okay, so that was pulmonology. And then we have rheumatology. So rheumatology is like your autoimmune joint, spine, skin conditions, your ankylosing spondylitis, your HLA-B27 conditions, your gout, your rheumatoid arthritis, your like your lupus, your Sjogren's, those kind of things that have skin manifestations, joint manifestations, sometimes GI manifestations. So the bulk of it was knowing when to recognize how to tie this constellation of symptoms together. You have your uveitis, you have your scleroderma, knowing when to tie it together and be like, hey, this person has this autoimmune condition and we need to refer them to a rheumatologist. So that was the bulk of what we were taught with it, and when to do like joint aspirations, differentiating a septic joint from just an osteoarthritis situation, So I enjoyed it. It was a bit, because nothing in rheumatology is ever certain. Like there's some conditions, like 40% of these conditions will test positive for this, but the other 60% won't. But it doesn't mean they don't have it. And I was like, I like definite things. I don't like this. Maybe. But I did enjoy learning more about these conditions that I didn't know about before. So, and then patient evaluation, more techniques, more doing physical exams. I think we kind of focused on populations at this point because we did. We had a newborn visit, which was really cool. We went to the hospital that is in the same campus as my school, and I got to see a baby that was born like the day before. So cute. elevated. So cute. And, you know, we got to do all these exams that we were just told about, and, you know, just in the clinical setting, which was cool. We also had an inpatient visit at another hospital within our system, and we got to, you know, do like a full note on the person, a full HPI, a full status note, a full SOAP note. And I got to hear my first murmur, like, in real life. I was like, because, you know, you practice on your classmates, and everybody is healthy and young. Somebody will have like one little thing in their eyeball, and that's it. But going into clinic, and this patient has like a laundry list of things wrong with them. They've had like 10 surgeries, and you have to cover everything. So it was good practice for knowing exactly how to, you know, keep up with that. And I heard my first murmur, and I was listening. I was like, "You have a murmur?" And he was like, "Yes, I do." I was like, "I heard it." So that was also cool. And another experience that we had genital teaching assistants, so that we could practice our breast exams, cervical exams, and digital rectal exams. That was another experience. Now it's good because you don't want your PA or your provider that's doing a digital rectal exam on you to check your prostate, doing, you know, a pap smear on you, checking your rectum. You don't want to be the first human person they've ever examined. Like, that's not cool. So we had these real life people, and they've been trained to do that. And it's actually a really cool thing because some of them had like certain interesting anatomy, which is why they signed up to be genital teaching assistants. So they will guide you and be like, this is what this feels like. We practiced on models first, and then on them, and it's like, you should do this. Make sure you offer them the tissue. Make sure you use lubrication. Make sure you're gentle. Cut your nails. You know, stuff like that that you think about, but you don't think about until you're actually there with your finger in somebody's butt. So that was another experience that I think was really helpful with patient evaluation. And then we kind of learned charting and EHRs. It doesn't really matter because every different hospital has a different EHR, and you'll learn it at that point when you get there anyway. But that was the patient eval 2. So we did patient eval 1, this is patient eval 2. And full disclosure, we had OSCEs, of course, like I described in my previous videos, and that's where you have a fake patient or an instructor, and you have to do this whole set of exams and stuff on them. And I failed one of mine. Okay, let's discuss the tea. Let's discuss this. I was late. I take full responsibility because I'm not one of these, I was late. Forgot my stethoscope, had to run back and get it. Got in the room, completely forgot to do like half the things that the prompt told me to do, so I bombed that option. Now I passed the overall, because it was 3 stations, I passed overall, but that one I did not show proficiency, and I had to go back and do it again. Guess what? I'm still here. Just recognizing what I did wrong, and my instructors were very supportive because they were like, do you want to review the video? It was recorded, so you get to see how you do and what you do, and there's things that you do that you don't realize until you see yourself on camera, like you're leaning over the patient, or you're really in their face, or you elbow them almost because you're not spatially aware of what's going on. So I did watch the recording, and I knew where I messed up, so I wasn't going to argue about it, but it's helpful that that resource is available. And my instructors were like, we know that you know what you're doing. It's just, you know, if you had come on time, you wouldn't have this issue. And I was like, yeah. So I got to redo it, and everything was fine. You know, being able to accept when you fail at something and know the reason why, and then move on from it, I feel is a really good skill to have at any point in learning. So it didn't. I just want to disclose it fully here that I did not pass one of my OSCEs. And then I went back and did it again. I passed it. So okay. So that was the spring semester. The spring semester is probably when I worked to the least, I'm going to say, through the entire didactic year, because having to learn all this material and study, there was some weeks we had just exams on exams on exams. There was barely any space to breathe. I would be in school all week. I wasn't trying to do a 12-hour shift on the weekend, so my job, they barely saw me, but somehow it worked out. You know, my supervisors were super understanding, which would probably not be the case with a lot of jobs, so this is special case. And spring was kind of, it's the dead of, it's spring, but it's January to what, like freaking April, so it's the dead of winter. So it was miserable, it was cold, everybody was just over it and tired, but we got through it because there was no time to whine, you got to suck it up. So that was the spring semester, and I'm glad that it is over. Okay, so moving on, after the spring semester, obviously we have the summer semester. So by the summer semester, this is our last didactic semester. So it's kind of a nice feeling, like, okay, after we do this one, we don't have to do this marathon of studying and learning all over again. It's going to be a different mode of learning with its own anxieties. So summer semester was 16 credit hours. We took clinical med 3, we took behavioral medicine, and we took clinical therapeutics. So Clin Med 3 had 7 modules, and it was 11 credit hours. Behavioral medicine, which is like psychiatry, 2 credit hours, and then clinical therapeutics was 3 credit hours. So altogether for the 16, sorry. Okay, so the modules for Clin Med, we're going to start there. We had emergency medicine, pediatrics, geriatrics, surgery, ortho, ophthalmology, women's health, or OB-GYN, and that was it. 1, 2, 3, 4, 5, 6, 7. Yep, so those were the modules for Clin Med. Now, I'm going to start with emergency medicine. So emergency medicine, the thing about it is, the ER is really a constellation of all the body systems. So I feel like it was placed at this point because by this time we've reviewed like the heart, the lungs, you know, kind of a lot of different things. So anything can come into the ER. You get a lot of heart and lung stuff, palpitations, I can't breathe, you get fevers, you get injuries, you get trauma, you get accidental or intentional, unfortunately, poisoning. So you gotta know your toxicology and your toxidromes. And you just get all of it, and they just present as like, I'm sick, I don't feel good, I want you to make me feel better. Or they come in from an accident and they're not alive or talking, and you gotta deal with that too. So the ER is a mixture of everything, so you have to know a little bit about everything as a medical provider if you're gonna be in the ER, and that was what the module focused on. We took some of our classes with the 4th year med students at my institution, which I was like, this is a little intimidating, like, bro, but it was fine. Like, I mean, we're learning the stuff, and you kind of realize, okay, I know this stuff, I've been told a lot of these things, so I recognize them, and I just have to know how to process and how to approach a lot of these situations. The main goal a lot of time in the ER is just to, you prevent loss of life and limb, and you know who to consult it out to. Are you going to call burns? Are you going to call plastics? Are you going to call cardiology? Are you going to call pulmonology? Are you going to admit them to the ICU? Do you need to call the hospitalist? What are you doing? Are you calling opto? Are you calling derm? Like, who are you going to call after you stabilize this person to get them to the next level of their wellness? So we also did disaster training. I don't know if this is under the ER, but we did this. We went to this place in Indiana that has like a simulated subway station. It's a National Guard facility. And we got to do like disaster triage. So if there was like a, I don't know if whoever's from Indiana would remember this. There was like a stage collapse at a concert at the State Fair one time, and there was just mass casualty. So as a healthcare provider, if you were in that situation, they're kind of teaching you how to triage people. You're walking wounded. If there's electrical injuries, people that aren't breathing, people that are bleeding out, how to kind of just stabilize them until professional help arrives. As a healthcare provider, knowing this and being able to apply can really make a difference to a lot of people's lives. So I think that was really good training. I liked that experience. The National Guard facility was a little creepy, but it was good. It was a good experience. And then we did our ACLS, which, you know, advanced cardiac life support, and knowing what to do, knowing what rhythms to shock, knowing what rhythms not to shock, and what medications to pass, the cycle, your compressions, your breaths, all of that stuff. So emergency medicine is definitely very dynamic. It was a good module. I thought it was handled pretty well, and they give us a lot of good resources. Then we have pediatrics. So I like kids and I like working with kids, so it was nice to get the knowledge behind all this and the rationale behind why some things are done the way that they're done. Of course, you have your well child visits, because peds spans everything from newborn to like college age if they're 18, like up to the age of 18. So you're dealing with your newborn conditions, you know, your milestones, developmental milestones, autism, recognizing at what age, what screening tool do you use, childhood conditions, congenital disorders, let's see, the genetic disorders, your syndromes, recognizing those, feeding, healthy weight, percentiles for growth and height, and all of that stuff for the younger kids. And then when you get older, you have to do like your HEADS assessment for like safety and suicide risk and drug use and peer pressure and driving and seatbelts. So it kind of runs the gamut, and self-esteem and like mental conditions, depression, all these things. So it was nice to just run the gamut of peds care. And our instructor for this, she's a PA as well, our professor, and she actually had training. I believe the program she went to was childcare focused, and she really knew her stuff, and I enjoyed her instruction and the way that she approached it. She'd be like, this is what we actually do, but this is what you're supposed to do, so you can gauge what you're going to do, you know, but this is what the rule says. And the vaccines, I know so much more about vaccines now that I really appreciate. vaccines, duh, but just knowing like why you give certain vaccines at certain times, which ones you can give together, which ones you have to space out, all that stuff. So the peds module I felt was pretty good. Then we had geriatrics, from the little babies to the old people. Geriatrics, we mainly did like your age-related changes in recognizing what they are and what screening tests to do for like your, your senior adults. The things you have to consider: do they live alone? Have they lost their spouse? Polypharmacy, because because they have less physiological reserve as elderly people, when you give them meds, you have to consider that it's going to give them a side effect. And are you going to give them another med to counteract that side effect? We're going to give you this med, but it's going to make you constipated. So we'll give you something for your constipation, but that's going to make you, tired. So we'll give you something to make you stay awake. And then they're on like 6 or 7 drugs. So knowing the Bears criteria, all that good stuff. And then end of life and palliative care and advanced directive, power of attorney, all of those things we studied in the geriatric. And very important, knowing that a lot of these individuals are on Medicare because they're at the age that they qualify for it, and knowing what Medicare pays for, knowing what the USPSTF recommends, the task force for screening, and knowing that because you don't want them to pay for a test, to go get a test that Medicare is not going to pay for, number one, and that isn't recommended for their risk level, if that makes sense. Like if you have somebody that's 75, they've never smoked a day in their life, and they don't have a family history of certain conditions, you're going to screen them for different things than a person who smoked for 30 years and stopped, or has smoked their whole life and just never stopped. They were just about that life. So knowing lifestyles and how you tailor the screening and tests that you do on older people. Osteoporosis, huge one there, for our little old ladies, knowing what kind of scans, how to interpret their DEXA scans and their risk level, and how to manage them, and the side effects of the drugs you use to manage them. So the big things, hearing loss, hearing aids, dentures, oral care, all that stuff was covered. I thought it was a really good module, and I enjoyed it quite a bit. And then, of course, your dementia, your cognitive decline, knowing what's normal for cognitive decline versus what is not for an older person. Just because somebody's old doesn't mean they have to lose their mind. And it's good to kind of recognize when something is off, because a lot of the time older people will present with a delirium from something as basic as a UTI. So we were taught all that, and I thought it was very well done. Then we had surgery. So a lot of PAs go into surgery, obviously. Surgical subspecialties employ a lot of PAs because there's so much work to be done. So we not only covered the procedures, but we covered pre-operative care, post-operative care and nutrition, recognizing fevers, recognizing post-operative complications, and knowing how to handle them. So surgery is not just, this is what you do, this is what you cut, this is how you do it, you scrub in, no. Pre-op, post-op, intra-op, all of it was covered. Knowing your 5 W's of post-op fever, which I could probably say in my sleep now. Wound care, burn units, how to handle those. Trauma, because a lot of surgery is elective, which means the person chose to have the surgery, but a lot of it is non-elective, and under that non-elective surgical umbrella, you have your trauma. And trauma is a very, very, very dedicated subspecialty of surgery. A person has a traumatic event, you gotta assess them, you gotta stabilize them, and then you send them off to surgery and you try to fix them. So you have to know how to do your primary survey, try to figure out the mechanism of the injury, because that's gonna figure out how you're gonna fix it. Then you do your secondary survey, and then after you do all that, you figure out what surgery is going to be done, what surgery needs to be held off on. Is it a pregnant patient? Is it a pediatric patient? Is it an older patient? Do they have comorbidities that are going to, affect how you do the surgery, and what kind of anesthesia you use, all of that stuff. So I thought it was very well covered. Knowing your GCS, GCS vague, you got to intubate, all that stuff. So surgery was a good module. Then we had ortho. I feel like we had a ton of ortho in my program, but for good reason. Our instructors in orthopedic, practicing orthopedic, so this kind of thing, had all these people, come in, talk to us, all that, real good stuff. But I recognize that we had that much ortho because back pain is under ortho, and back pain is so common. You have to know how to differentiate an emergent back pain from just a chronic back pain, and how to manage it. So I feel like that's why we were getting so much of it. And I can differentiate back pain in my sleep now because we got so much of it. But we also did like our shoulder stuff, hand and wrist, pediatric musculoskeletal stuff, your special tests to see what's actually injured. Is it a bony injury? Where's their trauma? Is it a tendonitis? Is it a tear? Is it a sprain? And the main thing I took from it is that rest and activity modification will fix so many things. And then if that doesn't work, then you kind of escalate and see if you want to do joint injections and all these new therapies that are coming out to help manage pain in different areas of the body. And that your goal is kind of to establish functionality for the person. So if you have an athlete that has an MSK problem or an injury, you're going to manage them differently than a little old lady, because she just wants to be able to like brush her hair and knit and stuff like that. She's not trying to throw curveballs. So you have to kind of look at your patient profile and adapt your treatment plan to their ability to pay and their ability to comply. Physical therapy is a great tool. You know, all of those things are taught to us in MSK, and I thought it was really well handled. Okay. Then we had ophthalmology. Ophthalmology I thought was fabulously done. Fabulous. Because we had I feel the top ophthalmology clinic in town. The owner, the physician that owns it, and his daughter handled our opto module. And opto is so detailed, like there's so much that goes on with the eye. They did a great job of breaking it down, letting us know when to recognize red flags. When to recognize red flags is the hugest thing. If you see this, if you test for this, make sure you protect it. Put a little thing over it so that nobody can touch it. Don't let them do this and that. And consult opto versus you can manage this versus is this a glaucoma? What have they had done in their history? What was the mechanism of the injury? When did it start? Is this an allergic situation? A scleritis? Is this a bacterial keratitis? Is it a contact lens gone awry? You know, all of these things. I really think they handled it well, and they give us enough information so that we could recognize almost any kind of mechanism and pathology of the eye, and use the necessary diagnostic tools to figure out what kind of plan we're going to follow. So our opto module was really, really good. I really liked it. And then women's health, another super detailed module, because women are just amazing creatures and you have to understand everything that happens with them. I felt like with women's health, once you got your cycle down, know what surges when and what falls and what maintains what, you get that down. Every drug, every pathology, you know where the problem is in the cycle, and you know what drug you're going to use to fix it. Now, some of the lab tests you have to do are a little, obscure, and knowing the levels. And then also, with women's health, you have your obstetrics and you have your gynecology. Obstetrics is obviously the baby stuff. Gynecology is the plumbing and making sure everything is working fine with disease, pathology, and otherwise in your cycle. So with obstetrics, we had to figure out, preterm labor, normal pregnancy, infertility, knowing what to do with when labor is progressing. What do you do if labor isn't going the way you want it to? What if your patient starts to get preeclampsia? Managing gestational diabetes, hypertensive conditions. Patient was hypertensive before they were pregnant, developed it while they were pregnant, multiple pregnancies, in vitro fertilization, fertility treatments, all these things. So that's your obstetrics. And then recognizing emergencies in labor, like your placenta previas and abruptios, which not necessarily that those themselves are emergencies, but knowing what to do when you see those kinds of things, and knowing all of the visits that need to be done during pregnancy and how often, and danger signs to look for, and how to educate the mom, and how to know first-time mom versus they've had 4 kids, all that stuff. So that's the obstetrics. Then you have the gynecology. That's from when they Tanner stages, when they first enter puberty, when they have their first cycle, if they're anovulatory, if they have a syndrome like Turner's, that's going to affect how their cycle works. Knowing dysmenorrhea, all the oligomenorrhea, all the different things that can happen with the menstrual cycles. Understanding contraception, because a lot of people will put trust in you as a provider if you go into that field, to advise them on what kind of contraception to use, and more importantly, what kind of contraception to stay away from, because you can have some bad side effects if you put the wrong patient profile with a certain type of contraception. They will not be happy with you. So that was women's health, and I felt like we covered it pretty well. And you also have to know your breast stuff because your ovarian, cervical, and breast conditions are all tied together, because when these cycles happen, you have proliferative breast changes and glandular breast changes. So knowing that all that is tied together and what is protective of a certain type of cancer versus what is a risk factor for a certain type of cancer. So I felt like we did a very detailed job in women's health. Okay, so that's Clin Med. Now we just have the clinical therapeutics and behavioral med. Clinical therapeutics was a course to apply all of the information we've been given thus far, and we were given patient vignettes and profiles, and we had to figure out what the patient had, know how to treat them, know how to educate them on their treatment, and know what follow-up to do. So it was tough kind of figuring out what exactly they wanted us to do at the beginning, but by like the second or third time we kind of got it, like, okay, you guys want us to manage what they're coming in with acutely, their chief complaint, and also recognize like this is a hypertensive patient, so we can't give them this, or this is a patient with this condition, so we need to make sure this is managed as well. And they would give the same case to two different groups, and then we would present and we would compare and contrast. Well, why did you do this? Why did you choose this drug? Did you know this drug is like super expensive? Like, why did you put them on that drug? Did you know they have to take 8 doses of this a day? They're not going to do that. It's like a 14-year-old. You know what I mean? So stuff like that, it kind of helped. And we worked in groups, so you would pick each other's brains and know how you would proceed for, if you have this patient in front of you. And we got to do oral presentations so that we could practice because clinic was coming up. So that was good. And then also we had lectures. So the days that we had we would have lectures on the prevalent conditions. So we had like a lecture on hypertension management, diabetes. I really enjoyed the diabetes lecture because now I know so much more about the condition than I ever knew before. And it's a horrible condition. That's what I learned. And it's really important to manage it because otherwise it will jack up like every single thing in your body. We learned about our asthma, our antibiotic use, and we learned about complementary and alternative medicine and like supplements that people use that they might not tell you about as a patient because they're ashamed to say they use it or they don't think it matters. And then it's like a CYP liver inducer or inhibitor, and it messes up the other drugs that they're taking. So like kind of knowing to ask patients about that was a huge part of the complementary and alternative medicine lecture that we got. And then antibiotic use, knowing to not just hit everybody with the big guns because that is how we get superbugs. That is how we get resistant organisms, and everybody is screwed when we have resistant organisms. So a combination of getting information on actually how you prescribe these things. We practice writing prescriptions. It's kind of funny because you're not really going to do that anymore. It's all electronic, but it's nice to know, okay, the suspension of the drug and how much you want the pharmacy to give out, and like leaving a little bit extra, for example, with a pediatric patient if it's a liquid, because we all know kids take their medicine real well and they don't smack it out of your hand and waste it. So knowing that you should give a little bit of extra just in case there's problems like that, and educating the patient on finish your antibiotics even if you feel better, stuff like that. So clinical therapeutics, I feel, was a good kind of mesh of the clinical knowledge and then the application of the clinical knowledge. And then finally we had behavioral medicine, which is basically psychiatry. It was very detailed. We had a PharmD handle a lot of it, so she was very insistent on making sure we knew about the drugs, because somebody comes in with a condition, you're either going to send them to therapy or you're going to give them the drug. And a lot of these psychotropic medications have hella side effects, and you don't want to be giving a drug that's going to give someone a side effect. And like suicidality is a huge one with like your tricyclics, for example. You really want to be careful when you're giving these medications to make sure that the patient profile you're giving them to is not somebody that is going to give them a worse outcome than what they came for in the first place. We covered like our schizophrenics, our personality disorders, our depressive disorders, our substance abuse and impulse control disorders, and then childhood psychiatric situations, psychiatric emergencies. All of those things were all covered. And then we kind of had to make sure we understood the difference between the DSM-4 and DSM-5 because of the changeover. So that was a huge part of the class, like, oh, with DSM-4, this condition, kleptomania, is now called blah, blah, blah. Or what was the other one? Like hypochondriac. A hypochondriac is now called blah, blah, blah. So knowing that, because someone will come in with an existing diagnosis from a DSM-4, and you have to chart them as a DSM-5, but they know, the beast that they're dealing with and the name that they call it. And if you keep calling it something else, you might confuse your patient. You have to bill appropriately, have your correct ICD-10 codes, all of that stuff. So that was all covered as well. So I felt like it was very, very detailed, very detailed and very well fleshed out. Okay, so that was the summer semester. I was actually able to work a little bit more in the summer, I felt like, because we were still taking a lot of exams and stuff, but it's the last didactic semester. So GPA wise, you kind of know where you stand, if you're good or otherwise. And I was able to be like, and I had also got my learning system down pat. I knew that I always had to make a plan, because what I struggled with, I think in the earlier semesters, was that I wouldn't make a plan of, okay, this exam has 8 PowerPoints I have to look at, but PowerPoint number 7 has 150 slides, which that's not an exaggeration. We had some lectures that really had that many. And I'm like, okay, even if it's just 7, that one alone is going to take me so long. So just writing out the work that is to be done way in advance, and then apportioning your time properly, and then knowing the stuff that you kind of understand and the stuff that you're going to have to go over 2 or 3 times. So I got my study habits really, I got them down in the spring semester really, but by the summer I was on it. But the spring was the harshest one. I studied the most in the spring because of all the content we had to do. I spent the most time studying, like, oh my gosh, it was crazy. So by the summer it was a little bit better, but I was still studying because, you want to finish strong in didactic. So, like, learning how you study best. If you don't study well in a group, don't force it. If you don't study well in a group, go study by yourself and then review as a group. You should be using the group to your advantage. But if you come for a group review session and you haven't studied, like, why are you here? Because then you'll start to feel really bad because you don't even know what everybody's talking about. Like, know how you study better. Some people study much better if they're just in a group and everybody's quiet and studying. Some people need to be by themselves in a quiet room where they can speak out loud. Some people need, dry erase markers on the whiteboard for them to use. Some people need to watch a video. Some people need to re-listen to lectures. I, on occasion, would re-listen to lectures because they were recorded at our institution. But rarely would I have to listen to an entire lecture unless I was just really sick that day or just spaced out. Because you don't want to listen to it. You have to sit in the lecture in class and then go to it again. That's double trouble. I don't want to do all that. Anyway, so clinic is coming up. Like I said, we had our white coat ceremony yesterday, and it was such a really nice culmination of all of the work that we put in. It was really symbolic, and I really enjoyed it. It's anticipatory because we know the work that lays ahead of us. We also took our PACRAT exam, which is like a mock board exam. So the PANCE is the one you take at the end. After you take the PANCE, you can start working as a PA in the United States. But the PACRAT is like, it was 225 questions, 3 hours and 45 minutes, and we were not supposed to study for it. Because I am who I am, I did a couple, question banks beforehand, but really it's just to see how much you remember just off the dome, and the scores are aggregated. It's like from a 120 to like a 1 something, and the higher you get, the higher the percentage chance that you're gonna pass the PANCE when you take it. Now keep in mind, we're not taking the PANCE for another year. A lot can happen in here. You can study a lot, get much better, see clinical applications of things you didn't understand before, and be able to answer questions much more efficiently. Or you could just lose all your knowledge, because you're just lazy. So, but we take one now, and I believe to take another in a few months in April. So at that point, it'll give you another score that is predictive that you're going to pass the PANCE when you do take it. And they've done studies to kind of correlate the score of your PACRAT and you passing the PANCE. So it's to catch early when someone maybe is in danger of not passing, so that you don't waste your money and have this tragic outcome. So I did really well. I beasted the PACRAT, honey. Let's keep it 100. I beasted it, and I was very glad because I was a little nervous about. I was like, how am I supposed to take an exam and not study for it? Like, what? But it worked out, and I was very, very happy with my PACRAT score. And it also breaks down the areas that you're strong in compared to the national average, because PA students all over the country take it, and it breaks down the areas that you're not so strong in. By percentile. You were in the 98th percentile for cardiology. I think it was like hematology or something. I was like in the 10th percentile, which I knew. I didn't know my hematology stuff, so I didn't feel bad about it. But I was like, dang, I need to study hematology. I need to know my anemias and my blood disorders and my oncology. I really need to know that. So that was good. PACRAT was good to know where you stand. So for clinic, it's less marathon 8 to 5 classes and big exams. For clinic, we're going to have 4 weeks of each rotation, and we have our core rotations of emergency medicine, internal medicine, surgery, psychiatry, outpatient medicine, women's health, pediatrics, community medicine, and family medicine. So everybody does those. And then we have 2 electives at my program. So you can do another core one if you really liked it and it's somewhere you want to work. And you can do both your electives in that, or you can do 1 elective in one elective in something else. You can do an elective in something that we don't do a core in, like a derm or something like that. And then you have specialty selective. You get 1 of those. And specialty selective can be more in-depth, like versus surgery, you can do pediatric cardiac transplant surgery, or you can do pediatric burns, or pediatric oncology, or foot and ankle stuff, like whatever the heck you want to do. You can choose it, and like you'll be able to rotate through there, especially if you have connections with someone or a facility or an organization that you know you might be interested in working with. You could set that up, you know. So we get 2 electives and 1 specialty elective, and we will see how it goes. But everybody does the core. So the way I've been set up, my first rotation is an hour and 15-minute drive, Friday, Saturday, Sunday, 7 a.m. to 7 p.m. The rest of my summer is going to be trash. I'm glad I had the fun I had now, because I'm going to be like on the road or in clinic every weekend for the next month, for the foreseeable next warm weather we have. I'm going to be indoors. It is what it is. Turn it to the game. The rest of mine, though, because of where I live, I'm like 10 minutes away from my rotation after that, which is ER. I'm like 15 minutes away from my surgery rotation. And I'm literally 5 minutes away from the hospital where I do my psych rotation. So I really can't complain. We were told that there would be some driving involved. It's fine. It is what it is. I'm more nervous about the fact that every month you're going to have to acclimatize to a new hospital, a new preceptor, a new cafeteria, because I don't like trash food. Just the fact that you have to, get that done every single month is a little bit, to me, more intimidating than even the material of the medicine itself, because we will be studying. You're expected to read up on stuff because you will get pimped. It will ask you questions on anatomy and surgery. It will ask you to interpret labs in inpatient and ICU. It will ask you, what the vaccine schedule is supposed to be in peds. They will ask you, what treatment plan you're going to go with in the ER. You're going to be suturing, so your clinical skills have to be on point. We've done some suture labs. My sutures are trash. I'm honest when I'm trash. I know when I'm trash, because when you're trash, you can fix it. If you don't know you're trash, how are you going to fix it? My sutures leave much to be desired, but I have time. And I have suture, and I have a skin pad, and I'm going to be practicing on pig's feet and oranges, and we will get there. So, you have those clinical skills that you're expected to develop, and then the grading is going to be different, because we'll still have grades, because we're on roll for credit hours. It will be a combination of the EOR exam, the end of rotation exam, at the end of each rotation, except your electives and specialty selective. And your preceptor will give you an evaluation as well, as far as what kind of student you are, how eager you are to learn, how punctual you are, and if you're ready to practice yet, which I fully expect the answer to be no at the beginning. But again, if you know you're trash, you can only get better. And then we also have to do a presentation on either an interesting case that we see or a condition that we see over and over, and the management of that condition in the clinical setting. So there's still some work and some studying that you're going to be doing, and taking an ER exam for every single rotation except the electives and specialty selectives. So it's not like the schoolwork is completely done, but the majority of it is now showing up, learning, and doing. So we're transitioning over to becoming clinicians. Okay, I've been talking for a long time. This video is about to be an hour long. If you're still watching, thank you so much for dealing with me. Okay, in conclusion, I'm really, really satisfied with the quality of my education. I can say this now because I'm at the end of didactic, and everything I'm going to be taught, I have been taught. I am very, very, I have a newfound respect for, I understood medicine was hard before, but just seeing the magnitude of everything there is to be learned, and how much trust is put in you, and how much you can affect someone's life, their existence, their mortality, it's kind of heavy. So I have a deep respect and appreciation for medical providers, healthcare providers, everybody that is a PA, a doctor, an NP. I am really, really super respectful of the craft and the service that they put in, and how much you have to know to make sure you do no harm and you actually contribute to a patient's wellness. So I have a better understanding and appreciation of it. The collaboration in my class has just been amazing. I don't think I would have made it through didactic without my classmates. Everyone has been so helpful, so open. Even if it's like they emailed the professor and the professor said, oh, this table on this slide, I would take an extra look at it. And then they let everybody know, and you're like, oh, I wasn't even gonna look at that table. And then now you look at it, boom, 3 points right there. Collaboration, when there isn't this spirit of competition, is so refreshing, because I'm used to people like trying to undercut each other, especially in like medicine and healthcare, and you know, everybody's super smart and everybody's trying to show how smart they are. I'm super appreciative of my classmates for the culture that we have developed in our class. And I know some of y'all saw my YouTube channel, so hi, thank you. I appreciate you guys so much. All right, let's see. Everyone who has reached out to me on this channel, everyone who I have communicated with, who has asked me questions that I've tried my best to answer questions on, first of all, thank you so much, because you guys are very sweet. You've given so many compliments, and like there's people who have gotten into PA school after like, I didn't do it, you got into PA school, but people have asked me questions and I've tried my best to answer as honestly as possible as far as how they should go about things. And then I'll get a message from them a couple months later and they're like, I did what you said to do, whatever, and I got it. And I'm like, yes, you know, it wasn't me, it was you, but it's nice to be able to contribute to that. And something that I recognize is that information is power and perspective is key. When you are able to get the perspective of someone that is in a program or in a situation that you hope to be in, it kind of changes things and it gives you the ability to picture yourself in that situation. And I know a lot of people don't like to talk about the situations they go through as far as, you know, medical school or PA school or NP school, and that's changing because of the way social media and the internet and all of these platforms that we communicate on are changing as well. But it's very refreshing to see people be open and honest about the things that they go through and the tools that they use for success and the things that they don't do and the things that work and don't work for them. And at this point, I'm going to say, like, especially for, you know, people of color, women of color, I think we make up like 2 or 3% of the PA workforce in general, which is like tiny, because that's barely anything. I mean, there's not that many PAs to start with, and then there's not that many black PAs. There's not that many PAs of color at all. So I feel like it's really important to get the visibility out there. I found a ton of PAs of color who were able to share some of their experiences with me via Instagram, via Twitter. I found some really good podcasts, and all of this stuff was just really mentally supportive and stimulating. And it's not just PAs of color, obviously. Any kind of PA, any kind of person that chooses to share the information that they have, because information is so, so valuable. It says, silver and gold I have none, but I could give you this, you know, I could give you this tea that will help you get through this, so that if you feel like, oh, I don't belong here, I've struggled so much, why am I struggling? It's like, newsflash, we all struggle. I mean, some people are geniuses, but it's very, very comforting to be able to get the perspective of someone that is in the position that you want to be in, and then being open about it and sharing with you, so that you have kind of an advantage in that way. So I'm really glad that I can share this information and my perspective, and at this point I'm really excited, because it appears that it is helping people out there. And I'm just really excited to be at this point in my career. Like, I got my white coat. It was such a fun ceremony, and I'm getting ready, you know, to go to clinic. I have all my little tools and stuff. I got my scrubs, my stethoscope. I'm gonna show up the first day and not know a daggone thing. But it'll be fine. Okay. I made it less than an hour. I was worried this was going to go over an hour and you guys are going to click out and be like, man, she's talking too much. Thank you for watching my videos. Thank you for coming to my channel. I will be trying to give some, get some more videos up here. You know, I said that last time too, but I'm going to try to talk about, especially my first rotation, try to give some perspective on that, what it's like to be a PA student, you know, in clinic, because you're not just in a vacuum. You know, you have your preceptor, but you have other PA students, you have NP students, and you have medical students. And everybody's, you know, trying to get the game on, trying to get their stuff done, trying to get the competencies checked out. So I'm going to try to make a video about that as well. I appreciate you guys, and like I always say, maintain an attitude of gratitude, and your days will just be much, much easier to get through. No matter what is going on, find the things in your life that you're thankful for and focus on those, because there's always going to be something to complain about. There's always something to complain about. But if you have an attitude of gratitude, it goes a long, long way in making life more enjoyable. All right, that is it. I am done. I'm hungry. I'm going to go get me some food. Thank you guys so much for watching, and I will see you in the next video. Bye.